So, since the first case of HIV was detected in Vietnam in 1990, Vietnam has made significant strides in addressing the epidemics. And we are now still in a concentrated state, and HIV prevalence is stabilizing as of 0.3% in the general population. For the healthcare financing system in Vietnam, before 1989, the Vietnamese health system is generally publicly funded, and we are providing free of charge healthcare services for all. Since 1992, we introduced the concept of socialization of healthcare and implemented the social health insurance schemes. Up to now, we are applying a mixed healthcare financing system. However, only 64% of people are having health insurance, and we observe a large share of out-of-pocket payments for healthcare service. Regarding the benefit package, since antiretroviral treatment for HIV patients is currently financed by projects supported by international donors and the National AIDS Program, ART has not yet included in the health insurance plans. Last 3 years, we support the Vietnam Authority of HIV Control in national strategic plannings, and we forecast that the resources needed for HIV program in Vietnam is rapidly increasing, and it would double by 2015 and triple by 2020. This figure show a huge gap in resource needs for HIV program in Vietnam. The situation is more difficult when Vietnam is now becomes a lower middle income country, and the resources, the funding from international donors is rapidly decreasing. When we analyze the resources for different types of services, we found that HIV-related services, including antiretroviral treatments, methadone maintenance treatments, preventive mother-to-child transmission, and voluntary counseling testing, accounted for about 70% of the total resources needs for HIV program in Vietnam. And it's so that in the rapid degree of resources for HIV in Vietnam, we need to improve the efficiency of the system as well as reducing the cost. And as such, we implemented a survey, so-called the HIV-related service user survey, to collect information from the patient, and to estimate the patient preference and their expenditure regarding their health care. In this presentation, I focus on two objectives. The first one is to assess the current coverage of health insurance among patients with HIV/AIDS and their willingness to enroll and pay for health insurance plans. And second, to estimate the budget impact of scaling up social health insurance coverage for patients with HIV in Vietnam. We conducted a cross-sectional survey among 1,100 patients at 8 hospitals in Hanoi and Nam Dinh province, and we assessed the preference of patients using contingent valuation. The budget impact was estimated for different scenarios with regards to the social health insurance expansion plans, percentage of enrollment, the premiums, and the projection of HIV treatment costs. In this figure, we can see that the less than half of respondents are having the health insurance card, including about 16% of respondents having the card for the poor. As for the health service utilization and the cost, on average, patients with HIV/AIDS visits inpatient care about 0.39 times a year, and for outpatient care about 3 times a year. Adding to the total healthcare cost annually about $400. So this is equivalent to the unit cost of the antiretroviral services for patients. In this figure, we can see that social health insurance currently accounting for only about 7.7% of the total healthcare costs, excluding antiretroviral treatments. And in this figure, we forecast the needs for antiretroviral treatments, and we can see that the total number of people needing ART will increase 50% by 2020. As for the coverage targets of antiretroviral treatment services and social health insurance of governments, we aim to cover 80% of ART for patients by 2020, and 100% of people living with HIV have social health insurance by 2020. In this scenario, the budget impact of expanding social health insurance coverage for patients with HIV/AIDS would be about $56 million by 2020. And in this figure, we present the budget impact for different scenarios, including the current coverage of health insurance and the scenario that health insurance will cover antiretroviral medication, ARV and OI treatments, ARV and CD4 monitoring, and ARV, CD4 and OI treatments. As for the willingness to pay of the patient, in this figure, the y-axis is a percentage of patients who were willing to pay and enroll in a health insurance plans at a certain amount of premiums. We can see that at the current premiums of about $2.5 per month, about 70% of patients are willing to pay for health insurance plans. And the social health insurance mobilization, if expanding coverage for HIV patients by 2015, can contribute about $19 million for the total healthcare cost for HIV patients. In regression analysis, we identified some factors associated with the willingness of patients to file for social health insurance plans, which including the socioeconomic status of the patient. Notably, we see that the different level of health administration contributes significantly to the willingness of patients to pay for social health insurance. And patients with different health status, for example, anxiety or mobility problems, also respond differently for the willingness to pay for social health insurance plan. So we come to some policy implications. The first one is that we observe a low rate of social health insurance coverage among HIV patients in Vietnam. However, we also found a very high willingness to pay for social health insurance in Vietnam. And expanding social health insurance for HIV patients in Vietnam is technically possible to mobilize resources for healthcare for HIV patients. However, consideration of geographical and socio-economic status is necessary to encourage patients to enroll and use their health insurance cards. I would like to acknowledge the contribution of our colleagues at the Vietnam Authority for HIV Control, Hanoi Medical University, and the Health Economic Policy Research Alliance. Thanks very much.